Welcome. You're listening to The Rural Road to Health, the podcast about rural health careers and rural communities. I am your host, Dr. Veronica Rasic. Hello everyone, our guest today is Sadie Lavelle Cafferkey, who is a registered nurse working on Achill Island in the Republic of Ireland. She is currently also doing a PhD with Trinity College Dublin. Hello.
Hi, thank you for having me.
Thank you for taking the time to speak with us today. So I guess we're going to just kick off with the first question, which is a little bit about how you decided to go into rural nursing and kind of the background there, if that's okay.
Yeah, of course. So it kind of happened by accident. I was working in quite a busy acute hospital in Dublin. And during the pandemic, we had a little window where we were allowed to travel again. And I hadn't seen my parents in 9 months. So I went home to Achill Island and I got an email through one of the agencies saying, oh, there's a job in the nursing home on the island. And at the time I was doing my master's and I said to my mum and dad, would I be crazy to move home? And I kind of weighed up the pros and cons, and my rent was going up in Dublin and we knew we were going into another lockdown. So I kind of bit the bullet and said, yeah, I think this is the right choice for me. So it kind of happened by accident. But my PhD was not an accident because my master's, I focused on the acute setting in Dublin, and I realised if they had such a lack of resources, what are the lack of resources in the west of Ireland that my health area is? So that's why I chose to focus my PhD on the area that I'm in now.
Very nice. And so what has it been like working and living on Achill Island again?
It is a bit of a change. My closest hospital is an hour away, so it's quite significant. Even working in the nursing home, the team there is fantastic and they really know the residents, which is amazing. But you are working sometimes nearly with few resources because there's one doctor for the whole island at the moment, so it is quite hard. But then on the flip side, I'm very lucky because I look at the ocean every day and I have the freedom to be able to go for a walk when I want to. So it does, the pros outweigh the cons.
And so you said you're working with the nursing home at the moment. So what other kind of health services are available on the island? So you said there's one doctor. I assume that's a primary care service.
Yeah.
What else is there on Achill Island?
At the minute, there is, as now I can stand corrected about this, there's a public health nurse, but she's not permanent. She's part-time because she comes in and out. And we did used to have a permanent public health nurse, but to my knowledge, there isn't one. There was a day service for the elderly people. It's like a day centre. As far as I know, that hasn't opened up yet because they haven't got the staff because of COVID. So there's very, very few healthcare settings on the island, which is unfortunate.
And with the kind of population that's on the island, what does that look like? Is it mostly kind of working age people? Is it people that have retired? Are there children? What's the population like there?
So at the minute, there's about 3,000 people on the island. That usually doubles in the summer. And as we all know, there's a beautiful film called The Banshees of Inisherin that has been set in Achill. So I would say that would increase probably even more. But usually in the winter, there's about 3,000 people, and it is an aging population for sure. Because people in my age category, we tend to finish our school years, we leave for university. Not a lot of us come back. We would tend to come back maybe for family, but not to live. Then on the flip side, you'll sometimes have people coming home to raise their families. But unfortunately, it is more of an aging population.
Mm-hmm. And what is it like if you do need to access secondary services? Do you have to leave the island, or is there something available there?
No, you have to leave the island.
And how do you leave?
We're very fortunate we have a bridge, and you would need to either have someone that can drive you, or you can get a bus. Now, to be fair to Ireland, Transport for Ireland have really helped the transport situation. So we have now 4 buses coming in and out of the island a day, which is a lot better than what it was, because it used to be there was 1 bus in and 1 bus out, and that was it. So Transport for Ireland really is helping the rural side of things.
Nice. And what about emergency services? So if something has to be done quickly, how does that happen?
We have a fantastic fire brigade system. We have a really good Coast Guard and lifeboat, because a lot of the things that would happen, a lot of people would have to be airlifted. So the Coast Guard and lifeboats are very much our essential services that we rely heavily on. The ambulances, unfortunately, sometimes they may be depoted 30 minutes away from the island if you're lucky. But usually they are in the main hospital, main town, which is an hour away.
Okay.
Yeah.
And so with your work within the nursing home, are you the only nurse there? Is there another member of the team that helps you, or what does that look like?
No, I'm very fortunate in the nursing home that I was in, because I've actually left it in the last month because my PhD has stepped up a level.
Yes.
But I'm hoping to get back to it because I was doing agency nursing in that nursing home. I was very lucky. There was a very good team there in that nursing home. So you would have 2 nurses on, and you would have 3 to 4 healthcare assistants, and they were phenomenal. So there was a good support in that nursing home. There really, really was.
Very nice. And how many people are they looking after?
It has capacity for 31, but when I was there was 25.
Very nice.
Yeah.
And with that, moving on to kind of a bit about your PhD, what is your PhD and how did you decide to start it?
So my PhD is looking at a nurse-led model of integrated care for people with substance use issues in resource-poor and rural settings. That is a working title, so it might be a bit much of a mouthful. But what I'm hoping to do is, so it's a mixed method study. And for the quantitative part, I'm hoping to assess the burden within communities by providing estimations of prevalence within the local needs. So I'm getting data from the hospital inpatient systems, I'm getting data from the ED systems, and I'm also getting data from the treatment demand indicator, which gets sent to the EMCDDA in Europe. So I've got 3 secondary data sets, which I need to start analysing. And if any of your listeners have quantitative and SPSS experience, please send them my way, because it is not my area of expertise at all. So it is a massive learning curve. And then with my qualitative piece, I'm looking at the perspectives of people who've used substances, have tried to access services, and identify any gaps in their pathways that they try to access services. I'm looking at the healthcare professionals. So I've separated the healthcare professionals to the nurses and doctors, and looking at their thoughts and experiences in both providing substance use care and also if they feel anything needs to be enhanced, if there is a need for this service, which I'm hoping from the secondary data it will show. And I'm very lucky in the health area that I have chosen to do my PhD. I have 3 acute hospitals, I have 2 residential treatment centres, 54 GP centres, and a prison. So I'm very lucky. Now, I say this, but the landmass to get from one section to the other is massive.
Yes. And with the kind of data you've gathered already, do you find that the services are needed most in kind of city settings, or are you finding there's quite a need in regional and rural areas as well?
So at the minute, I haven't been able to analyze my data yet because I'm still waiting on one more data set. But from my lit review, it is very, very evident that there is a need for rural healthcare. Because even when I was looking for nurse-led models of care in general, I found 21, but there was only 2 that focused on a rural setting. So that is like a finding in itself.
And what have you kind of learned through the literature reviews about addiction services in rural areas?
There's a massive need for integrated services. There is a massive need as well for nurses to be trained and upskilled. This is quite significant. And in doing that training and upskilling for nurses, there was a theme of stigma coming through, but nurses felt when they were trained and skilled in this section of nursing, they actually were more open to doing it. And I feel like once we train the nurses and give them the skills they need, it actually can provide a very integrated, comprehensive, holistic service for people.
Mm-hmm. And when you say kind of integrative and nurse-led, what does that mean and what does that look like?
So integrated would look like you would be maybe working in the primary healthcare setting in the areas where you are, and they might have satellite clinics. So you're not separating out these clinics, and you might not even call them the substance use clinic. You might call them something like the healthy options clinic. And it's a nurse that runs it maybe 2 days a week. So people don't feel like they're being looked at nearly and judged going into these places, because you have to remember as well, when you're sitting in a rural doctor's surgery, you will meet your next door neighbor. So if everyone is in the same waiting room, that's more integrated care. But if you separate out someone who is waiting to see the nurse because of their addiction, you're segregating them, and that in its own is causing stigma. So if you have everyone in the same waiting room and you don't even call the clinic something specific, it's just maybe the healthy options clinic, it helps integrate that care because you don't want to segregate it.
Yeah. And is there a reason why you've gone with kind of nurse-led? Is there evidence to show that that's a better model if it's kind of the local nurse leading it rather than some specialist coming in to lead the service?
There is actually from the literature review that I'm working on at the minute, there is a lot of evidence supporting nurse-led models of care, particularly when nurses can prescribe, because when you have a nurse with the patient and individual themselves, they get to know them and build up a rapport quite quickly. And there's a lot of evidence, especially from the UK and the US, where nurses can titrate, can prescribe and facilitate someone's detox in the community and their addiction support.
Mm-hmm. And is there anywhere currently in Ireland where this is happening already?
So there is the healthy addiction treatment model. It's called the HAT model, and that's in an urban setting in Dublin. And the nurses in that are trying to lead a nurse-led model of care in an urban setting. And they basically the study they did underpinned by the Brenda model and the Frames model and the biopsychosocial model. They developed a holistic model of care, and what they found was the clients themselves were in favour of the nurses promoting a nurse-led model of care, and they also found that the clients themselves wanted nurses to prescribe because they felt that the nurse knew them better and knew their case better. Yeah, that was a really, really interesting finding to come out of that study, and it actually trickled down into the other studies that I found, that nurse prescribing is a massive thing that people want, and there is hopefully big movement on now in Ireland to get nurses prescribing.
Amazing. And with the kind of work that you've been doing, how do you feel that this would be able to be applicated or help in rural communities?
This is where I wanted to do the lit review and get the needs analysis, because I want to develop a nurse-led model of care that's very adaptable and flexible. So I'm essentially taking the best of all the nurse-led models of care that I'm finding and putting them all together so they can be applied to any form of rural or resource poor setting. So it might not be in a high income country like Ireland. It could be in a lower income or middle income country. And that's really important.
All right. And is there anything that has kind of surprised you in the reviews that you've been doing?
Definitely the nurse prescribing was a big thing that I wasn't expecting to come out. Another thing that I was not expecting to come out was having nurses with their scope of practice. That was a massive thing to come out of the literature. And like we all know, nurses are very stuck to their scope of practice, and that is what keeps us safe and everyone else safe. But I wasn't expecting it to be shone through in the literature. So that is actually really, really interesting to come through.
And is there anything that you feel that you are going to take from the things that you've found out and try and implement them into your model?
Oh, absolutely.
What you're working on, and what are those?
Oh, definitely. Things? Yeah. So there's definitely the training for nurses and upskilling them. And what I would love to do is see more training and education for addiction in a university setting. At the minute, I was actually given a massive opportunity to lecture as a research assistant on the Understanding Drugs and Alcohol module in Trinity College Dublin. So I was given the opportunity to teach the nursing and midwifery students, and the nurses came from all different disciplines. So that was really good as well. They came from psych, ID, general and children's, and I had the midwives as well, which was fantastic. So if I could see a little bit more modules like that coming through, that would be amazing, because it sets up the nursing student to have in their minds, okay, well, there is another avenue of nursing that we can go down.
And what made you decide to kind of look into addiction services and kind of focus your research that way?
I think that comes from my clinical experience. Because when I worked in the acute hospital in Dublin, we had a lot of infectious diseases. So we looked after a lot of HIV, hepatitis, alcohol detox, and we had a lot of people coming in who may have overdosed on heroin. So I had a keen interest in that area from working from there. And from my nursing training, I always focused my lit reviews and work on any form of addiction relating to substances that I could.
Yeah, fair. And what have you found the most challenging about kind of becoming a researcher when you're also a nurse, or kind of taking that path through nursing towards research, if that makes sense?
Yeah, no, that does. And that's actually a great question, because I sometimes find that nurses, they're like, oh, research is not for me. But it is. Like, we as nurses are needed to do research, because we are the ones that maybe see things in clinical practice that other people may not see or other people may not realize. But by doing our research, it is really important, and our research helps our patient care enhance, which is really important, because at the end of the day, we are our patients' advocates. So if we can enhance our practice and our care, then we're definitely advocating for our patients. And I think that nurses, if they're even thinking of doing a master's or a PhD, they should just definitely go for it. If there's any nurses listening to this and want to do a PhD, you can ask me any question you like. It's no problem at all.
There you go. Anyone who's interested, questions to Sadie? And with kind of support that you've had, were there people that were kind of important in helping you kind of try research? Or is that something that you've independently kind of moved towards?
I think for me, it was a natural progression from my master's to do a PhD. But I am very, very fortunate in the support system that I have. I have two fantastic supervisors, so Professor Catherine Comiskey and Dr. Fintan Sheeran. They are just amazing researchers in their own right, but as supervisors I am very, very lucky to have them. But I also have support from family. I have very good friend support, so I am very, I suppose there's no other word for supported. I have a lot of help. Like, my mom and dad are amazing. They, like, mum will cook me dinners, and I know I've said it before, but like, people say it takes a village to raise a child. It genuinely does take a village to get someone through a PhD. And I genuinely have an amazing village behind me. So I am very lucky in that sense.
And do you find that certain parts of the PhD itself have surprised you? Have you enjoyed particular aspects of the PhD process?
Yeah, I really enjoyed the lit review and finding different themes and different articles and research and evidence. A part that I'm not enjoying so much is the statistics, because again, that's uncharted territory for me, so that's something I need to brush up on. But from this PhD, I've been given experience in working on other projects as a part-time research assistant, and I've been given opportunities to lecture and teach, which is amazing for me, and it's definitely the route I want to go down.
Very nice. And kind of thinking about future ideas or future projects, is there anything that you would be interested in exploring further? Are there any kind of people you're looking for to help with these projects?
Yeah. I think as a researcher, you will always go down the research rabbit hole. So even when I was looking at my own PhD, I was thinking to myself, oh gosh, I'm looking at nurses, but I'm not, I didn't specifically say midwives, but in the HSE, the health service setting that I'm working in, the maternity hospitals are actually linked onto the general hospitals. But with the midwives, I actually do think that is a whole other postdoc piece of research.
Yeah.
I think that would be a whole different lit review, and so I do think there is more research to be done. I don't think I'll ever leave research, if I'm honest, particularly for rural and addiction, because it is definitely something that is an issue and it's not talked about. And I think having the opportunity to talk about it is really, really important.
And kind of to sum up our conversation a bit, so what do you feel has been kind of the best parts of your kind of rural career and rural journey so far?
Oh, that is a good question. The best parts. I suppose one of the best things is, if you've ever been to Achill Island, you'll know it's just this place where it instantly steals your heart. And to be able to work here and do my PhD here, I consider myself very, very lucky. But I do think working in rural settings, it has opened my eyes, because I was very fortunate to have been in an acute hospital where we had resources at our fingertips. It was the staffing was good and the specialities were there and the resources were there. So when you work in a rural setting, you definitely become more autonomous as a practitioner. And you realize that you're actually more skilled than what you know, and give yourself credit for. So definitely it has opened my eyes. I don't think I'll ever go back to a massive city. But I'm not sure if Achill is forever either. So I'll have to definitely keep that open.
Thank you very much. And just to help anyone who might be listening who'd like to get in contact with you, is there any way to do that?
Yeah, you can get my LinkedIn. I actually don't know what my username is. Isn't that ridiculous?
That's all right. I will put a link in the description below.
Thank
the
you.
podcast episode. Well, thank you very much for taking the time to speak with us today. It's been very interesting hearing about how things are on Achill Island and in general what you're doing with kind of addiction services as well. And thank you all for listening to us today.
Thank you so much.
Next time on The Rural Road to Health, we'll be speaking with Dr. Tarek Jagnarin. He is a doctor living and working in Guyana, and he will share his experience about working with Indigenous communities.